Good afternoon, everybody. Today's session will be in English because we have the honor to have our distinguished friend and colleague, Dr. Antonio Rampoldi from Niguard Hospital in Milano. He's well known interventional radiologist, especially in the field of embolizations and vascular interventional radiology and oncological interventions as well. So he was so kind to come for a few days in Thessaloniki and share his experience with us. So first he will speak about embolization of benign prostatic disease and hypertrophy. And after him, we have a short presentation of some technical difficulties of the procedure from our radiology resident, Dr. Fotiadi. So, Dr. Rampoldi, if you like, please start your presentation. We can share the presentation in a moment, and you may start.
Good afternoon to everybody. First of all, I would thank Professor Zigdakis for the kind invitation and to share my personal experience on prostatic artery embolization. So we can start with the first slide, introducing the pathology. Few slides for introducing the pathology. We are speaking about BPH, and the histological definition of BPH is a disease process characterized by stromal and epithelial cells hyperplasia, but that involve the central part of the gland, so-called intermediate transition zone, and the hypertrophy of this area causes a reduction of the channel of urethra here, and could cause a lot of symptoms for the man. Epidemiology data show us that more than 6% of male population worldwide are involved by BPH, and quite 50% of men more than 60 years as symptoms related to BPH. And this pathology is diffused worldwide. The etiology of BPH is hormonal induced, is involved the transformation of testosterone in dihydrotestosterone through two enzymes, 5-alpha reductase, type 1 and type 2. And the dihydrotestosterone acts at the level of prostate, at the level of urethra, at the level of bladder. One of the most important things is to distinguish between BPH and other causes of LUTS. What is LUTS? LUTS is low urinary tract symptoms. So BPH can lead to bladder outlet obstruction, is defined BOO, and BOO is responsible for LUTS. But consider this, it is very important. LUTS are not only related to BPH, because you can have a patient who has BPH but not LUTS, and in this case, no intervention, no drug, no embolization, nothing at all. But also, you can, more important, you can visit patient with LUTS, but without BPH, because above all, if you have patient with small prostate gland with large post-void residual volume, the pathology could not be only related to prostate, but also to bladder. So take in consideration this, because lots could be caused by a lot of pathology. Bladder tumor, stricture, infection, presence on foreign body, and so on. And which are the most important symptoms? How can you define lots? It's important to separate lots in two groups, so-called storage symptoms and so-called voiding symptoms. Storage symptoms are frequency, urgency, or nocturia. What does it mean? How many times you have to void during the night? Voiding symptoms, hesitancy, decreased stream, incomplete emptying, straining to void. Why is important to distinguish storage symptoms and voiding symptoms when we speak of prostate artery embolization? Because as our data, the data of our experience will show you after, PIA, that means embolization, impact above all on these symptoms. You have the patient get better in frequency, urgency, and nocturia. Voiding symptoms compared to TURP, PIA has less success than TURP. So it's very important to distinguish between this type of symptom and the other. Diagnosis is done, we know that the diagnosis is done through visit the patient, his history, and controlling some blood tests, PSA, function of urinary function, and also as a test, a patient has normally an echo scan, and after we need to sometimes to do more complex tests as MRI. As a functional test, the patient has normally urofluometry. And at the end, the possibility for symptomatic patient are a lot, watchful waiting in case of mild symptoms, medical therapy, minimally invasive therapy, surgery. These are the guidelines of European Society of Urology, and PIE as a role here is not considered until now in the guidelines, but could be placed, in my personal opinion, some for particular patient before the medical therapy or before surgery. So the most important thing is how to counsel the patient, and for our type of treatment, the most important thing is patient selection. And the typical patient of my experience are these two. If you consider this old patient with a permanent catheter or relatively younger patient with symptoms related to BPH. So, the starting point of embolization. First human, first who refer for embolization with human was Demerit, 2000. Before and immediately in same period, other paper on animal study about embolization. But the first paper involving two patients was the paper done by Francisco Carnevale from Brazil in 2010. His paper was prostatic artery embolization as a primary treatment for benign prostatic hyperplasia, preliminary result in two patients. And immediately after, the second important group, European group in this case, the group of Portugal from Professor Pisco, and published this paper again on PAE, on prostatic artery embolization. What is the rationale of PAE? It's important to know that the rationale of embolization are two, because we have a static component and dynamic component. Static component is similar to the component, to the rationale of fibroid embolization. So you have a reduction of prostatic volume by ischemia and hypoxia induced by embolization and result in apoptosis, necrosis, and formation of fibrotic tissue. And also, immediately after, reduction of protein synthesis and inhibition of secondary growth of a prostate for lower intracellular input of testosterone. But there is a dynamic component. Sometimes after embolization, during follow-up, we have no particular reduction in volume of a gland, but we have significant result, symptomatic result. This is in relation to dynamic component. Dynamic components means modification of the stiffness of the gland. So dynamic components means decreased number of adrenergic receptor resulting in decreased neuromuscular tone. If you control the elasticity of a prostate immediately before and after, you can see that the elasticity is more elastic, the prostate, after embolization compared to previous. Which are the indication, and now is the most important point, for BPH, in my experience. Three groups of patients. First of all, patient with BPH, symptomatic BPH, with moderate to severe LUTS. How define moderate or severe LUTS? There is an international score. It's so-called IPSS score, and is able to define, after I show you a picture of IPSS score, BPH tell you if the patient has important or less important symptoms. And patient with moderate to severe LUTS who is taking tablet but failure of medical therapy, who has side effects of medical treatment. Consider that this group of patients involve younger patients, 50, 55, 60, 65, who has sexual activity. So each type of drug, medical treatment for BPH has important contraindication for sexual activity. Or a patient unfit to surgery. What does it mean? Surgery, I consider in general TURP, and after TURP, you have quite 100% of retrograde ejaculation. Again, the group of patients is a group of young patients who want to maintain orthograde ejaculation. So this type of patient could be a good candidate for embolization. The second group, and normally is the group with which we start the experience, a group of patients with permanent bladder catheter, not candidate to surgery for comorbidities. Is the patient who every month comes into the urologic department to change the catheter, is the patient who sometimes has infection, so must be admitted to the hospital for longer time. And last group, because it's last group not for importance, but because normally the number of patients in this group are very few. Patients with spine lesion or similar pathology, neurological pathology with insufficient of bladder function, for which self-catheterization is needed. In some cases, self-catheterization is difficult, and embolization could allow to self-catheterization. And move to contraindication. The contraindication of PIE, the true contraindication is the cancer. PIE is not an intervention for cancer. If a patient has infection, active infection, if a patient has large stones inside the bladder, if a patient has large bladder diverticular, that means a patient with a diverticular, with a neck larger than 15, 20 millimeter, urethral stenosis, okay, is mechanical stenosis. It's not done by prostate enlargement, neurogenic bladder, or impaired renal function. And relative contraindication is the volume of the prostate and the high volume of post-void residual volume higher than 500 ml. Why this? For the reason I told you before, because in this case, the problem is not only the prostate, the problem could be in large amount problem of the bladder and secondary problem of the prostate. So in this case, you have to be sure that embolizing, you can obtain some result. But in general, in our experience, we don't perform embolization in this type of patient. Which are the tests we ask before PIE? Okay, the patient must be symptomatic, IPSS score, IIEF score, sexual activity. Normally the patient has ultrasound, uroflowmetry. The most important thing is the residual volume. Qmax is important, but these two could be modified by personal situations. So the most important thing is residual volume. Okay, as blood test, creatinine level and TSA, and very important, multiparametric MRI. In each case, except sometimes we avoid MRI in case of very old patient with indwelling catheter, where knowing that there are some lesions possible at high risk of cancer is not so important. The most important thing is to avoid catheter. And in case of MRI with doubt for tumor, prostate biopsy. This is the IPSS score test. You see there are questions that involve the voiding part and the other, the voiding symptoms, and other questions related to storage symptoms. For example, as I told you before, frequency, urgency, and nocturia as related to storage, and the other are related to voiding. Another test that is normally done is a quality of life test that from 0 to 6, where 6 is terrible, 0 is good. And also here you have the IIEF test for sexual activity is the opposite. High number means good activity, low number means you have no, you are not able to do sex. And the procedure, how we perform the procedure, is done under local anesthesia. Vascular access means needs only a 5 French introducer sheath. Femoral, now we start from the beginning of the year with radial access, left radial access. It's very simple, it's comfortable for the patient. We need only longer microcatheter, but now in this year are available. Foley balloon, partially inflated with contrast, is a landmark for beginner. You can do also without balloon, but the problem is related to the ability of the patient to avoid lying on the table, and also is required if you have no great experience, because the balloon is able to indicate you where is the prostate. And also, last point, PIE is possible to do as outpatient procedure, above all if you use radial access. This is a typical vascular anatomy. After I show you more cases, but this is an angiography, iliac angiography in oblique projection, ipsilateral oblique projection. You see the typical anatomy. This is the EIL balloon. If you go down, you can find the prostate. Typical aspect of intra-parenchymal vascularization is this corkscrew aspect of the artery. And in this case, the prostatic artery is this one. You see, it's called the type 1 origin. You see the superior one is the umbilical, the residual of the umbilical. The second one is the superior vesicle. This one, with this corkscrew aspect, is the inferior vesicle of prostatic vesico-prostatic artery. This one is the obturatory. This one could be the ileorectal, and this one is internal putative. Which type of access, catheter and wires? Okay, as femoral access, we use as guiding catheter, 5 French. We use a pigtail, multi-purpose as SIM1, no more than this. As microcatheter, 2.0 or less, 150 centimeter length. And as guide wire, 0.16 supportive high torque multi-shapeable, or any 0.14 only in particular cases we need a hydrophilic double curve 0.16 guide wire. As radial access, you need something longer. As guiding catheter, just vertebral, 130 centimeter length, and microcatheter more than 170 centimeter. If you want to do so-called perfecting technique, as I'll show you immediately after. And the technique of injection. When entering the artery, you inject before nitro to avoid spasm and to open up better the vascular bed of the prostate. 200, 300 microgram of nitro, and then embolic agent. Normally we use 300, 500 micrometer embosphere, is a trizacrylate embosphere. We dilute 50% of saline and 50% of contrast media. First step, we inject with 1 ml of particle, and then 1 ml of saline, and then 3 ml of saline to push particle more deep inside the prostate. First step, proximal, and the second step, distal. Here is better, you can better understand how is perfecting technique. Here is your microcatheter placed in front of, you have the prostate here, you see the parenchymal aspect of the prostate, you start embolizing here, you stop when you are near stasis. You can see here the small particles that are inside the artery, and then if you want to do better, if you can add more particles, advance the microcatheter here inside, just to add more particles and to obtain better result. Okay, it's important to have available combined CT. What does it mean? Sometimes you have some doubt if the territory in front of you is prostate or not. Combining combined CT, are you sure that this one is prostate? And so you can embolize in this position. Consider that the vascularization of the prostate is a sort of is very difficult. Are involved a lot of artery. Is often is involved the inferior internal pudendal artery. Could be involved the inferior mesenteric artery. Is a complex network. Above all, at the apex of the prostatic gland. The most important artery enter the prostate along the lateral posterior wall of the prostate, and then divided into one branch directly to the central part, and the second branch immediately below the capsule go down and interconnect with this network done by inferior internal pudendal and sometimes by inferior mesenteric artery. One artery per side, no. Could be one, sometimes are more than one, sometimes could be two per side, one side also three. The anatomy is totally different, but in case of embolization of fibroid, the artery could be more than one. And I want to show you the standard classification, the classification done by the group of Francisco Cardevale about the type of origin of a prostatic artery. Type 1 means the type are 5. Type 1 means common origin with the superior vesicle. Type 2, anterior, from the anterior part of the hypogastric artery but alone. Type 3 from the obturatory. Type 4 from internal pudendal. And type 5, the other, because some origin could be totally strange. And I show you some case. You can see, and this is a case of a patient, ipsilateral oblique view, normally oblique angiogram, normally 35 degrees. You can see the division of the posterior branches, superior gluteal, inferior gluteal. You see the superior vesicle, and this is our inferior vesicle of prostatic artery. The microcatheter advanced, and this is here prostate. Here is internal pudendal. Different case. The origin in this case is totally separated and comes from here. This one is the prostatic artery, and you see the parenchymal effect of the prostate. In this case, another patient, you see the origin totally different. Obturatory artery. This is this type 3. Is the most simple to catheterize. And again, the parenchymal aspect of the prostate. And in this case, the prostatic artery, again, the balloon is here, you go down, the prostatic artery is this, type 4, the origin of from internal pudendal. But it's not always so simple, because consider that the patients are not young, the patients are old, and sometimes has atherosclerotic lesion. You can see here a very tough stenosis of the origin, but you can overcome, go inside and perform parenchymal angiography, and you can see the prostate, and from here you can embolize. Another patient with two tight stenosis, and this is the aspect of the prostate. or some different origin. In this case, the artery, the prostatic artery is closed, and you see a hypertrophy of epigastric artery. So the artery, the prostatic artery, comes from epigastric artery through revascularization of the obturatory, and again, this is a prostate. Sometimes the artery comes from posterior branch, from superior gluteal. This is a case of the prostatic artery. This is the patient was a doctor of my hospital, and the origin from superior gluteal artery. Sometimes you have more than two arteries each side. Here, one branch is here, the other branch is here. Both catheterized and both embolized. Some other, this is another case where the very small prostatic artery comes from accessory internal pudenda. In this case, it's quite impossible to engage these branches. You need to place a coil here to avoid extra target embolization. Place a coil here, close the artery, and then embolize from this position. Or you can have also connection between one side and the other. The microcatheter is here, I inject, and you see us the artery from the other side. Or in this case, you have a sort of middle rectal anastomosis. You see that, as I told you before, the network could involve the middle rectal artery and the inferior mesenteric artery. Or anastomosis between central gland and peripheral zone, like this. So, after showing the anatomy, I tell you something. Before the data of the literature and the data of our experience, I show you which therapy we perform during and after PIE. During PIE, we give antibiotics, 400 micrograms of ciprofloxacin. During embolization, again, painkiller and morphine API. And after discharge, ciprofloxacin and painkiller again for ciprofloxacin for 7 days and painkiller for 3-5 days. Which symptoms has the patient after the procedure? As for 1-2 days, symptoms related to voiding, sometimes a burning, or as symptoms related to storage, increase of frequency, urgency, and tenesmus. These symptoms last only 1 or 2 days, but it's important to inform patients about this. And in follow-up, which type of follow-up? Above all, functional follow-up. So IPPS score and Qmax, 3 months, 6 months, 1 year, and moreover, and uroflowmetry as residual volume. Contrast MRI only in patient with classified as PIRAS-3 as cancer surveillance. But other cases we don't perform MRI during follow-up. And now some data about literature. I show you this recent meta-analysis of 4 important RCT. The meta-analysis is really recent. This year was done by a Chinese group. You see meta-analysis of 4 RCT. RCT of China, RCT from Francisco Cardenale, the RCT from group from Switzerland and RCT from a group, a Spanish group. Different topic character are considered, because if you see someone treat patient with IPS score very low, the only one with IPS score significant is Francisco Carnevale. But if we do this meta-analysis and consider different parameters, we can see, and okay, meta-analysis, RCT, single RCT, did consider PIE and TERP. So for IPSS score and for quality of life, there are not significant difference between PIE and TERP, and also in IF score. The difference in favor of it's normal to this in favor of TERP is when we consider functional test as Qmax of post-void residual, but consider that TERP as the side effect of sexual dysfunction, and also the TERP is done in general anesthesia compared to PIE, as I show you, is local anesthesia with immediate discharge of the patient. And another paper I want to show you is the paper of Francisco Carnevale, first paper with 10 years experience. An important number of patients, 317. You can see that the distribution of variable is quite the same of our experience that I show you after. IPSS score is high, also quality of life, prostatic volume is significant. And here are the parameters considered. You can see that IPSS score drop down and then is maintained during the year, 5 years here. Okay, after 5 years the number of patients is low, but the decrease of symptoms is maintained during the time. The same level, the quality of life become really better and is maintained the quality of life, good quality of life. Prostate volume is refused. The reduction of prostate volume is percentage 15–20%. And also the parameter of functional parameter are good. Qmax is become better and is maintained. You have a slow reduction with year, but is maintained significantly better. And also post-void residual volume is significantly reduced. With type of complication, above all, the most important complication referred by Francisco Carnevale are hematuria, ejaculation reduction volume, self-limiting hematospermia, and some very small number of other. You had also taken consideration benign ulcer. The number is really very small. And here are our data, the data of my hospital. We start our experience 2013 with three patients at the end of the year. And then our experience continued during the year. You see that year after 29 cases, and year after 35, and actually we perform from 84 to 100 patients a year. And the age of this patient is decreased because the first experience was done with old patient with permanent catheter. Now the huge number of patient is patient with relatively young patient with symptoms without catheter. We continue to perform patient with catheter, but the great number are patient with LUTs. And here is the distribution of patient with LUTs and permanent catheter. You see that starting from here, from 2014, the number of patients with catheter is maintained the same, 25, 23, 24, but we have an increased number of patients with LUTs. Actually, last year 86, previous year 88, an important number of patients. And here a distribution of the total number of patients, 543. Last patient consider March 2021. We need to add the other 10 patients done in last month. The age, medium age, this one, the months with catheter, for patient with catheter, is the medium months is 7. IPSS score, but only for patient with LUTs, is high, 20. IF score was this one. The Qmax low, significantly low, again with patient with LUTs, 8.9, and post-void volume of post-void volume was significantly high. And also the medium size of the prostate is this. Time of procedure, medium 2 hours. Now, last period is decreased because we experienced, but you can perform a good embolization in less than 1 hour and a half, because you have to inject very slow, you have to control, and so on. Fluoroscopy time, this one, dose, medium dose is this. We had also great exposure, but again was the period of the first experience, and the total volume of injected particle was 13 as a median number. And this is the distribution of the type. Consider that we consider two sides, so 500 patients, 2 sides, and the most frequent vascularization in our experience is type 1. We have a follow-up of 412 patients among 543. The embolization was done bilateral in 471, monolateral in 72, not done in 6. What does it mean? As I previously told to Professor Zidakis, we normally also in old patient with permanent catheter, we don't study before vascularization. We try in any case to perform embolization. And in 6 patients, we find no vascularization at all of the prostate related to atherosclerosis. But it's important for us to try in any case to remove the catheter. The result follow up 12 months. Okay, patient with permanent catheter, 170. We have 75.5% of patients without catheter 12 months after procedure. And patient with LUTs, we have that is 70% of global amount of patients. We have 74.8% of clinical success. What does it mean? What does it mean? It means reduction of IPSS score from 20 to 10. The quality of life reduction from 5.9 to 1.8, a decrease of PSA from 3.2 to 1.8, and also a significant increase of Qmax. Qmax got better from 8.9 to 11.9. But also to be considered that 38% of patients with bloods stop definitively BPH drugs after PIE. Normally we stop 1 month after PIE, but at 12 months, 38% of the patient is not taking tablets and has no side effect related to tablets. This is our IPSS score after 3-6 months, 12 from 12 to 18 months, and from 24 months and 30 months. You see, this IPSS score move in the same way as other paper published. So you have a decrease, important decrease, 6 months, near 12 months, and then a little increase during the time. Which type of complication we had? Self-limiting hematuria, 12 cases, urinary obstruction, 11 cases, self-limiting hematospermia, 10 cases, benign ulcer, 5 cases. Benign ulcer was solved in less than 1 week with placing with some cortisone on the penis. And we had 4 cases of prostatic discharge of the tissue. You see a case, this one a case of third lobe protruding inside the bladder. Few days after, we controlled with echo scan, and you see the hyperechoic image at the top of the third lobe, and few weeks after, the patient discharged totally the third lobe, and we had a very important result. The patient referred to us, I'm able to void as at the age of 20 or similar. And I refer you also data from a patient who reached 5 years follow-up. That means patient PIE performed from November 2013 to March 2016. Totally patients are 41, and among them 20 with, at the beginning, catheter, and again 19 of 20 without catheter, and 21 patients with DATS, and success 16 among 21 satisfied, again maintain satisfaction with quality of life reduced, IPSS score that is increased compared to follow-up at 1 year, but you see is again significantly better. PSA is again less than the beginning. Qmax is better, and also the residual volume after embolization is significantly less. So, in conclusion of my speech, I can tell that PIE is effective and safe procedure. Improvement due to PIE is durable, and the positive effect are maintained during medium-term follow-up. No indication for prostate less than 45 grams. In case of large post-void residual volume, need for more complicated urodynamic test, you need to have combined CT. It's important to use full radiation protocol reduction protocol. And last but not the least, it's very important for us to work closely with urologists. Thank you very much before going inside the prostatic part.
Thank you very much, Dr. Rampoldi, for this excellent presentation. We are very lucky that there are some urologists from corresponding hospital we work with very closely, and perhaps they would like to make a comment before I ask the audience for any questions. You can open your microphones if you like, and you can make your comments or ask something.
May I?
Yes, of course.
Dr. Rampoldi, thank you very much for your excellent lecture. And thank you very much also for coming all the way from Milan to Thessaloniki, given the circumstances. My name is Yorgos Dimitriadis. I'm a urologist from the hospital very close to Achepa, and I'm really grateful to Professor Hatzidakis and Parsopoulos for inviting you to let us know more about this upcoming technique. I think that for prostate, for BPH therapy, we have many choices now. And I don't think that there is any patient that we can refuse treatment or let him with a catheter. So given the limitations of the intravascular treatment, the intraarterial embolization, do you think that there are many patients that have adequate kidney function for the contrast medium to treat properly with embolization?
But I think that, as I told during my presentation, the patient, the best candidate, in my opinion, two are my answer is an answer, not only my answer, but the answer that we decide together with my colleague, with urologist on my hospital, Dr. Borciati. The best patient to be candidate to PIE is the patient, is the patient who has, the old patient, the patient who has catheter and is not possible to be operated. Because you know that we have a lot of old patients, anticoagulated, or who is in therapy with aspirin, clopidogrel, and so on, at a very high risk of bleeding during TERP, or patient with comorbidity. This, in my opinion, is one of the best candidates. But second best candidate is a patient as me, of my age, with symptoms, patient who does want to take tablets, because I know that if I decide to take tablets, to take dutasteride, or to take alpha-lytic, tamsulosin, first of all, I can have retrograde ejaculation, and for me it's a problem. And also, dutasteride could cause important side effects, sexual side effects. So these two, for me, are the good candidates. Obviously, patient well-studied, above all the young one, because the prostate must be large, you have to be sure that the symptoms are related to obstruction. Because we have found also young patient with huge post-residual volume, post-voiding residual volume, who are referred to us because became obstructed. No, this could be no good candidate, because the problem in this case is not the prostate, but could be the bladder, as I told you before.
He asked also about renal.
Okay, about renal function. Okay, the total amount of contrast used for embolization is not too high. The limit we consider of creatinine level is 1.9 and 2. Above could be a risk of worsening the renal function. Below, if it's possible, I perform procedure.
And if I may, another comment. All the newer treatment options of prostate are very attractive, but they are also expensive. So what about the cost of the arterial embolization of the prostate?
The cost, consider that depends obviously from country to country, but the cost involved two things: the microcatheter and the particle. Microcatheter actually could cost less than 300 euro. In Italy is sold.
Here's about 500.
And particles, depends type of particle. Embosphere is more expensive, is 200 euro, 2,500 euro.
In Greece, in total, it's about 1,000, everything.
But consider that also you have no cost of hospitalization. You can discharge the patient. If you perform through radial access, you can discharge the patient 3 hours, 2 hours after the procedure. From femoral access, okay, you have at the end of the day, but you have no hospitalization.
Thank you very much again for coming and for your...
Thank you.
Thank you.
Thank you, Professor Dimitriadis, for these comments and questions. Thank you very much. Is there any other comment? I see Professor Tsetis is in... open the camera.
Hello, good afternoon. Good afternoon.
Hello, Dimitris.
Good afternoon.
Hello, Adam. Congratulations, Dr. Rampoldi, for this excellent presentation. I'm Dimitris Tsetis from University Hospital. Congratulations for your excellent presentation, and also congratulations to Professor Hadjidakis and Professor Parsopoulos for the organization and invited you. My question is, how often you need to re-intervene in patients? How often and what is the indication for intervention? And my second question is how you get your referrals. Do you get self-referrals, or you get through urologists, or how it's the situation?
The second question, I answered before the second question. Referral urologist, we work in together with the urologist. The urologists are our best colleague and are totally involved in this activity. Reintervention. If the first embolization, well done, doesn't function, has no sense to repeat that. That means that something was wrong. Something was not the good patient. Re-intervene in case of could be in case I have performed just one side because was very difficult. The artery was tortuous. The starting point was stenotic, and after 1 hour and a half of difficulty, I was able to embolize this side. I can stop and do the other side the day after. Or okay, this could be re-intervene if the only situation where it's convenient to intervene, where I perform the patient. I did a good intervention last year. Everything went very well. Patient has a good result, and after 1 year, 1 year and a half, symptoms return. In this case, could be, but the only case. Not repeat embolization if the first one was not able to obtain the result. That means that the patient is not a good candidate.
Thank you very much. May I ask another question, final question? What is the comparison of the prostatic embolization with the some new emerging percutaneous ablation therapies or HIFU? What do you think is the future of these therapies and prostatic artery embolization?
Okay, could be. This is a really interesting question. Ablation could be as a similar effect, because ablation means reduction of volume. We have no sufficient data to compare one with the other. Could obtain a similar result, but in my opinion, is not so safe, and in my opinion is also less acceptable, because I normally perform ablation in my hospital, ablation of a liver, of a lung, of a kidney. But if I think at myself as a patient, having a needle inside from perineal access is not a good. We had performed some. I performed two or three. We start with this this intervention, but I think it's really less comfortable compared to embolization. But we need the result. We need to compare one with the other.
Thank you very much, and thank you very much. Congratulations again. Thank you.
Thank you, Professor Tsetis, for this comment. Is there anything else from the audience? Any other comment or question? Okay, if not, we can proceed to the next short presentation from Dr. Fotiadou about some technical difficulties we encountered in our first cases here in Aheba Hospital. Please, Dr. Fotiadou.
Dear colleagues, my presentation is about technical difficulties of prostatic artery embolization in patients with benign prostatic hyperplasia. The aim of the presentation is to highlight technical difficulties that may arise during prostatic artery embolization. These images represent anastomotic collateral to non-target vessels like the rectal artery or the dorsal pinal artery. It is important to say that embolic material blocks only the prostatic arterial branches, so super-selective catheterization must be achieved. It is also important to recognize the correct artery, catheterize it, and advance the microcatheter as distal as possible to be sure that the embolic material blocks on the target vessels. Unfortunately, several technical problems may occur, like angiospasm, tortured or atherosclerotic arteries, presence of communication to non-target arteries, and identification problems of inferior vesical artery. Let me show you some examples in two clinical cases. The first case is about a man 65 years old with benign prostatic hyperplasia, with severe respiratory failure and inability to empty the bladder. In this image, we can see the prostate gland enlargement and the prostate heterogeneous signal. Now, we can see the procedure. A pigtail catheter was inserted into the aortic bifurcation. Catheterization of the left iliac artery with cobra catheter. Angiography shows the branches of the left internal iliac artery. Opacification of the inferior vesical artery. Despite the administration of diluted nitroglycerin, an angiospasm was observed, so embolization was not performed. Subsequently, a Simmons catheter was advanced in the right internal iliac artery. The right prostatic artery is shown by the arrow. Afterwards, a microcatheter was inserted, which was advanced peripherally into the prostatic artery. Unfortunately, the microcatheter was not possible to be more distal advanced due to tortuous arteries. Embolization started with specific embolic materials, but stopped prematurely due to anastomosis on the right dorsal spinal artery. 2 coils were also implanted. The patient was discharged the next day. Antibiotic treatment was prescribed for 2 weeks. Despite uncompleted embolization, patients showed a gradual improvement already after 1 week. The second clinical case is about a man, 75 years old, with benign prostatic hyperplasia, severe cardiovascular disease, and permanent bladder catheter. Angiography showed atherosclerosis of the left iliac arteries. The left prostatic artery was recognized as this one with severe stenosis in the ostium. It was able to catheterize this artery only with a guide wire, but microcatheter could not follow. On the right side of the same patient, we had problems with identification of the prostatic artery between 2 vessels. And we also had problems to catheterize them due to atherosclerotic disease. So the intervention had to be terminated. Thank you for your attention.
Thank you very much, Dr. Fotiadou, for this presentation. I would like to ask again if there is any question or comment from the audience or from Dr. Rampoldi about this presentation.
My comment is the 2 cases are really very difficult cases. The first one with one of the 2, the first one obtained the result, not clinical result. The first one.
The first one had
the first one obtained clinical result, removal of catheter, and could be. We define technical success when we are able to perform bilateral embolization, but we define clinical success if we are able to remove catheter. So for removal catheter, it's possible also, we can obtain success, also embolize one side. You try every time to embolize both, but it's possible also to obtain a result with one. And the second comment is, okay, the patients are not young, and it's possible to find, to meet stenosis, to meet plaque, to meet sometimes it's possible to overcome the difficulties, sometimes not. It's like this. In any case, in my opinion, with the old patient with permanent catheter, it's important to try.
And as we discussed before this morning about the communications, you told me that actually there are always some communications, and we should not perform angiography through injector or very big force, because in this way you might open the communication. So be very gentle with injection.
Absolutely, absolutely.
Very slowly with the contrast, find the prostatic arteries. Don't try to open the communications and make everything slowly and soft.
Gentle. As Dr. Fortiado showed you, there is a connection, important. Every type of a connection, every type of network. If you inject also with microcatheter, with force, also with the hand, but you force the injection, you're able to open up every type of collateral, every type of communication. So you have to do with the microcatheter inside the artery, you have to do injection. It's the same speed that you inject the particle. Same, to have idea of possible opening of collateral. And one very important thing is after injecting 3 or 4 ml of contrast, you have placed your microcatheter inside the artery. You have inject 1, 2, or 3 or 4 ml of particle. Do a control because with the correct force, but do a control because a collateral could be open, but always without forcing.
Okay, last question from me for today would be the most feared communications would be with the superior vesical artery and the rectal artery, perhaps, so that if you are not if you don't pay enough attention, you might have non-target embolization. In this case, there are publications about resection, surgical resection of bladder or rectum after PER, and this could be a feared complication for us. Do you think this is there is a way to avoid it, or this is so rare that we don't care about that?
Okay, my experience never had, fortunately, necessity to resect nothing, but for sure you need to take care of the presence of collateral. The most dangerous, in my opinion, are 2: the communication with the rectum and also the communication with the penis. Because okay, I told you that small ulcer of the penis solve in few days, but it's not a good thing. It's not a good thing. The perception of the patient is not good. So avoid above all communication with rectum, with penis, and also communication with bladder and with seminal vesicles. Above all, with seminal vesicle is very difficult to avoid. Transient hemospermia could be, but solve in 1 or 2 ejaculation. Another important thing is related to the cases I show you with very thin vessel going to the prostate, and that comes from accessory internal pudendal. I refer that I place a coil to avoid extra target embolization. But in this case, okay, with coil, I closed the communication with the benign artery. You can do, but taking care that the contralateral side is better. If no, if you place a coil in one communication with penile artery, and the other side is closed for other reason, you could have a problem with erection.
Okay. Thank you very much, Dr. Rampoldi. Is there anything else from the audience? Good. If not, we'd like to thank you for your attention this afternoon. Thank Dr. Rampoldi for his kind presence and presentation, and wish you a nice evening. Thank you very much.
Thank you very much.